Hello, I'm Penny Rubio. I'm the clinical lead for tissue viability, and this is bite-sized training on the new and revised wound management formulary. We're going to launch for this on the 10th of June 22, and this is just some bite-sized training to introduce you to some of the changes that we have made. Okay, so why do we have a wound formulary in the first place? Well, it's simple really. We want to help you. There are many dressings out there, all very confusing. We hear that a lot from people who don't know what's what and need to know more about dressings. And choosing the right one for the right situation with your patients can be tricky sometimes. So this is us trying to help you make good decisions. We're also trying to help the people who pay for all of these dressings. They're not cheap, they can be expensive, and what we're trying to do is make sure that you are using good quality dressings that meet the needs of your patients but at a reasonable price. So we are reviewing the dressings and trying to select dressings that go on the formulary that are cost effective. But most importantly, what we're trying to do is to make sure that patients get what they need. And we do that by having a comprehensive selection of dressings for the different sort of stages of wounds and different wound types, but also by structuring it in such a way and giving you guys education and guidance to help you to make the right choices for your patients so that you're getting the most appropriate dressing applied. So it's to help everybody really. So there's specific aims in this formulary that we've been working to. One of our biggest aims is to actually support you by doing the donkey work at looking at the evidence of some of these dressings and what works and what should be used in which situation. So we're trying to do all of the searching of the evidence and providing you with an evidence-based guideline from which it's safe for you to practice. In doing that, we hope to promote some continuity of care, rational prescribing, above all, safe and effective and appropriate use of the dressings, and promoting sort of cost effectiveness too. So lots of things we're trying to achieve with the formulary. So I don't know if you have seen, I would hope you have seen the previous formulary. It was written in 2015, which is obviously quite a long time ago, and we're sorry it's taken so long to review it and update it. One of the big reasons for this is that when the last formulary was written, one of the companies that makes the some of the dressings on the formulary very kindly offered to get it all nicely printed up for us. And the electronic document for doing that, we never got the master copy of, and so we were unable to edit it. It was all built in a software package that none of us knew how to use or had the software to do it. So we were stuck with either we have to rewrite the whole document or we can't amend it. So it's taken us some time to do that. We have now got the document into Word, but at the same time nicely laid out so it still looks presentable and very much like the old one. So we hope from now on that any amendments that we will be able to make quickly and easily. What we've done is we've printed off, we had a limited print again funded by the companies whose products are on the formulary, and on the launch day on the 10th of June we were handing these sort of copies out. We will be going through, we were asking people to sign for these, and we'll be going through the lists and working out which bases haven't yet had a copy in the coming weeks, and we will be posting that onto you. However, the master copy for these are on our website. Those of you not familiar with our website, it's on the internet, not the intranet. So you can just Google on any smart device Oxford Health Tissue Viability, and you will find our webpage. And this formulary is available for download on the Wounds tab. If you click on the Wounds tab and then scroll down, you'll find Oxfordshire Wound Management Formulary, and then you're free to print that off yourself should you require it. Okay, so the beginning of the formulary is a guide that it's part education and part guide for you guys. So when you're choosing the appropriate dressings for your patients, you need to be basing your selection upon a comprehensive holistic assessment of the patient and of the wound. So you need to be looking at the wound, identifying what stage of healing it's in, what tissue you've got there, are there any signs of infection, what's the moisture levels like? Once you've been able to assess it, then you can work out what the most appropriate dressing is. So if you've been on our wound assessments and management study day, you will be used to the TIMES framework as an assessment tool for wounds, looking at the tissue type, infection, moisture, edges and surrounding skin. And what the beginning of the formulary does, there's a chapter called Wound Categorization, and based on that assessment, you can identify in the guideline there what tissue type you might have. It will then tell you what your treatment objectives should be. So, for example, with if you've got a wound that's epithelializing, then your plan with dressings is to protect that area, protect those new cells that are dividing and the skin coming across the wound. So you need a contact layer to protect them. You also need to maintain an optimal moisture balance. So you'll need a secondary dressing appropriate to the levels of moisture. Too dry and the new cells won't be able to migrate. Too wet and they'll get damaged in a puddle of exudate. So it tells you your treatment objectives, and then it suggests what your dressing selection might be. So it will say you need a contact layer. The standard ones are Na Ultra and A Trauman. You could use a hydrocolloid, or indeed you could use a film on there. So it will give you what your options are of the categories within the formulary that would be appropriate based on your assessment for your wound type. So worth having a little bit of bedtime reading, looking at that lot and familiarising yourself, because if you don't know what you're doing, this is where you should be coming to. So after the wound categorization section, when we get to the sections where all the actual dressings are, you'll find, very much like the old formulary, that we're using a traffic light system, that the green there's a green section, amber and red essentially. So the green section here, this is a copy of the summary of the formulary, just listing the different categories and dressings that are there. So all the green stuff are your first line dressings, okay? So these are the things that are on the shelf as stock waiting for you to use and take out to your patients. They all get ordered via Halo. And you need to be communicating with your admin and your team lead in your base and your clinical development leads, excuse me, should be agreeing which out of these green dressings are dressings that we routinely use for our typical caseload. So if, for example, you work in a minor injuries unit, the chances of you applying compression bandaging are probably quite slim. So you wouldn't need to stock up on Actico bandaging or K2 bandaging in that area. District nursing, on the other hand, you will obviously be needing to stock up on some of those things, but there will be things on there that you may not use with your patients. So it may be that you the mollalast conforming bandage, that's toe bandaging. I don't know anybody that, unless they've got a patient regularly using it, that would need that on their shelves as stock. That would be something that you would order in when you've got a patient that you would need to use that for. You may be a team that doesn't really use very much tubular bandage, so like comfy grip, the tubey grip type stuff. And you may need very little of that on your shelf, or you may decide that you don't need it at all on there. So you'll be looking at what you regularly use in your team, going, yes, we need to order this, yes, we need to order that. And then you'll be coming to some sort of judgment as to generally how much stock you need for sort of like a 2-week period. So a team with a smaller caseload isn't going to need anywhere near as much stock as a base that has got several teams all amalgamated together. So your admin will be fairly clued up on based what they've had to order so far, as to sort of kind of what the volumes would be. But you need to agree a minimum and a maximum stock level. So your minimum stock level would be a trigger to your admin. Once the stock has got down to that level, that's when they should be reordering again. And the maximum stock level would be, yeah, this is regularly, we don't use more than this, so we wouldn't order any more. So if we're empty, we would need to order 40k soft to get us up to our maximum stock. So your CDL, your admin, maybe the resource nurses, you need to agree what your regular range of dressings is suitable for your caseload, and what's your minimum and what's your maximum stock level. And we're asking you not to hold more than 2 weeks of stock. You know, stockpiling 10 packets of every dressing size of every dressing you've got there when you never use the large size of the hydrofilm is utterly pointless and a waste of money. And God forbid it would then actually go out of date and you have to throw it out. So the idea is that you have 2 weeks worth of stock so that you've got a constant rolling as you need it supply of dressings. So that's the green section, and that you can order a pile of different dressings all in the one order. When you come onto the amber zone, these are all about patient-specific dressings. Now, amazingly and wonderfully, we now have a section on Halo where you can order the antimicrobial dressings, but you don't order them as stock to go on your shelves. If you have a patient that you go and see and you think, oh, I've got a wound infection here, I need some antimicrobials, instead of asking your GP to prescribe and potentially waiting 2 weeks, you'll ask your admin to order it then. They should order it on an individual order, and in the typing box at the bottom, you put the patient's NHS number, your reason for ordering it, and then how many you need for that fortnight based on, we use 2 10x10s 3 times a week for both legs. So that would be 4 each dressing change, 3 times a week is 12. 2 weeks, we're suggesting, would be 24 dressings. Now you would specify the number of dressings you need, and when your excuse me, when your admin goes onto Halo, Halo will tell them how many dressings are in a box. So they'll be able to see that the honeys come 10 to a box, so they'll need to order 3 boxes of that honey, and they will type in their NHS number, wound bed infection, using 2 10x10s, each leg, both legs, 3 times a week equals this many dressings. And then the powers that be that are checking the orders, and they do check each and every order that goes in, will be able to go, yep, this is an appropriate order, I'll just authorize it. If you're asking for 10 boxes of Iodaflex or 10 boxes of Zorflex, and you're just saying for a wound, they'll be calling you going, why are you ordering 10 boxes of Zorflex? How frequently are you seeing this wound? How big is it? How many do you use each time? And it will delay your order. So try very hard to educate your admin and discipline yourselves that when you're requesting this, to provide them with that information so that there's no delay. So the amber zone, patient specific, there's a list there of the ones that can be ordered on Halo, and then there are some patient specific which are basically the emollients and the barrier preparations, so things like your Derma S that need to be ordered on FP10. So you'd be asking your GP to prescribe those on FP10 for you, but you don't need any authorization or permission from us to do that. So that's the amber section. Then we've got the red section, and this is the restricted zone. And again, the red section is divided into 2. So you can, you need to be conferring with us about all of these garments, all of these sort of products in the red section. The pink ones, you'll be emailing us saying, I'd like some Clinizorb for this patient, Penny, and you'll be emailing the rationale. And I might be saying, okay, you're asking for Clinizorb, but you know, you're saying it's odour. Have you thought whether maybe you've got a wound infection? Is that the reason for the order? Yeah, we're using this, we're using that. And I think, okay, fair enough. Yes, you've already got an antimicrobial in, there's still really bad odour, it's distressing for the patient, we'll authorise the Clinizorb. What we then do is we complete a dressings request form. So on that form, we put the patient's NHS number, we detail what the dressing is, the order code, so the PIP code for the GP, what size it is, how many to prescribe, and then a rationale underneath it. And then we sign it. We have our signature on the bottom and the date on the bottom. And we will give that to you for you to give to the GP and say, we'd like this dressing for this patient. We've got authorization from Tissue Viability. here it is, please can you prescribe it? So that's the pink part of the restricted bit. You ask for our authorization and we give you the form to give to the GP. Then we've got the bottom bit, which is the sort of red zone, if you like. And these are products that you, these are products that you need to get through us, but not only have our authorization, but we will actually supply the products to you. So we are able to order these on Halo, and you will communicate with us. And if we think that's the right product, we will order it on Halo and we will have it delivered to your base. So Coban bandaging, for example, is there, Sorbion sachet, and the VAC dressings. So you've got the wound categorization educational bit at the beginning. You've got the dressings that are organised into green, amber and red. And then within that, each sort of type of dressing that you come to, so like wound contact layers, will have a series of symbols. So there will be a step up, step down option. So say, for example, you're using Atraumon as a contact layer and you think, well, this isn't good enough, it's sticking. You would look at the step up box and it would tell you what would be the step up product from Atraumon, which would be the Active Heal silicone contact layer. And then if you're using something like Sorbion or Cliniderm super absorbent and you think, well, the wound isn't, these are too absorbent now, the wound's not that wet, I need to step down. The step down arrow will tell you what you would step down to from those sort of products. The exclamation mark there is any cautions. So things like you shouldn't cut the Sorbion or the Cliniderm super absorbent or biotin adhesive, because if you cut them open, you release all the fibres inside and you don't want those fibres in the wound. Or maybe with the Cadexima iodines, that you should only be using the maximum of 50 grams in each dressing change and no more than 150 grams within a week. So if there are any cautions in the products that you're using, you would find them underneath that exclamation mark. And then the light bulb points to consider hints and tips about how to use the product. So more information about the product there. So I'm just going to run through some key changes with you, just so that you're aware of the main things. So some of you may be aware already that Tricotex is no longer available and that the substitute dressing for that now is NA Ultra. So that is your dry wound contact layer. We've got a new dressing onto Formulary that replaces a leave-in life. Now, you might not have used a leave-in life much. It's a foam dressing with a bit of absorbency crystals in there as well, and a silicone contact layer and border to it. So the leave-in life used to be on the red section of the Formulary. It was very absorbent or more absorbent, expensive and difficult for you guys to get hold of sometimes. We have put the Cliniderm foam silicone border onto the green section of Formulary, but to be used in two very specific circumstances. Please don't use this dressing as your simple adhesive dressing to go over the top of, any little wounds that you've got, a scab here or a scab there. It's more expensive than your cheaper options like Soft Pore and Hydrofilm Plus. So please don't use this dressing in that fashion. This dressing specifically, we've put it onto the Formulary for two reasons. One, as the dressing of choice on our skin tear pathway, and I'll mention a little bit more about that to you towards the end. So if you've got a skin tear, we've got guidance of how to deal with it, and this would be the dressing that you would be using on it. And the other thing is, as an adhesive dressing to go on legs underneath a hosiery kit. So trying to get a hosiery kit on top of pads is really quite tricky. Also, we don't really want to be putting adhesive dressings on legs. So, legs often have circulatory issues. We don't want to be ripping the skin with an aggressive adhesive and causing more of a problem. And we don't want some nasty adhesive chemical causing irritation to what is already sensitive skin when you have, say, for example, venous disease and varicose eczema. So this foam silicone border is specifically to go on a leg and specifically to go underneath a hosiery kit, which we are trying to encourage everybody to use as first line compression for venous leg ulceration. And this is to make that easier for you to do. Also easier for patients to change. So if you've got a patient that's able to deliver some self-care, then this could be a dressing that would really help them do that as well. So it's not as absorbent as the Leave-In Life. It's not a very absorbent dressing. It doesn't coat with large amounts of Exudate by any stretch of the imagination. So it's really only for low to moderately exuding wounds. If you've got quite a wet wound, this may well not be enough, and then you may well be into a contact layer and an absorbent pad. One of the other changes for district nurses, we have removed the sterile Exupad from your Halo orders. The sterile pad is indicated for people after a surgical procedure, only within the sort of first 48 to 72 hours. And actually, there are limited occasions when you'll be doing that. And if you need something, then you do have sterile gauze in your dressing packs and tape and the like. So on sterile contact dressings as well. So practice nurses, you will still be able to get a hold of the Exupad, but district nurses you won't. We are changing Zecuvit Plus to Cliniderm Super Absorbent Pad. District nurses, you will probably have seen the Cliniderm Super Absorbent for some weeks, if not months now. We've been evaluating it on a wider scale with you guys, and since we knew we were going to be having it on Formulary, it's been left on Halo. Advantages to this over the Zecuvit Plus, we found it's better because when we've been using this, there's been less of a demand for the Sorbian pads. Sorbian pads are still available, but use of this pad seems to have reduced the demand for them, and thereby introducing a cost saving. It's marginally cheaper than the Zecuvit Plus pad, this pad is, but whereas Zecuvit Plus is a combination of cellulose and super absorbent crystals, the Cliniderm super absorbent pad is all super absorbent crystals. So the Zecuvit Plus, the cellulose wadding inside is quite bulky, whereas the super absorbent crystals are much lower profile. So you'll see a big difference in how thick these pads are, with the Cliniderm being much, much thinner. And we have discovered that there's a really great advantage with that. When you've got a wound around somebody's ankle, foot sort of area that's really quite wet, and you've been using Zecuvit Plus to it, you've ended up making the foot and the ankle really quite big. And actually then we've been noticing quite a lot of problems with the shaping on the compression on legs like that, where people haven't been managing to get that graduated shape. Because you've got a big foot, you would have to shape with a lot of wool to get that graduated shape, with the calf being wider than the ankle. Whereas this lower profile dressing means you don't get such a bulky ankle, and you haven't got such a hard job to shape to make sure you've got that sort of graduated sort of compression. So we're pleased with this dressing. Sadly, since we've moved on to the new formulary, despite assurances that all of the dressings on the new dressings on the formulary were available and fully in stock, that doesn't appear to have been the case. And this dressing in particular, there's been a real supply problem, and we've been advised it may take some time to resolve. So for the time being, Zecuvit Plus is still going to be available until the Cliniderm super absorbent supply chain has been resolved. You will notice when you look in the formulary that you can't find an alginate in there now, and that's because we've replaced it with a gelling fibre dressing. So that's called Active Heal Aqua Fibre Extra. So a gelling dressing, other examples of that would be Aquacel, for example. The alginates and the gelling fibres do a similar sort of job. So they absorb exudate, they help with autolytic debridement, so management of slough. It's just that the gelling fibre dressings don't disintegrate. so you're safe to put them into a sinus, as long as you've got the tab out, because it won't fall apart inside. But also it tends to do what we call sequester the exudate away, so it locks the exudate away inside the dressing better than the Ergozorb does. And that's important when you come to talk about the amount of microbes you've got in a wound. They're all sort of, you know, bacteria and fungal stuff all sitting in your exudate. If that's all still in your wound bed, then you're risking developing biofilm in the wound, because the bacteria are just multiplying in the wound bed. Whereas if they're locked away, sequestered inside the dressing, then they're sort of kept at bay and less able to do as much damage. So that's why we've gone for the gelling fibre over the alginate, but they do a similar job. If you're looking for autolytic debridement in a wound, if it's wet, high levels of exudate, you'd be going for the Aquafiber Extra. If there's lower levels, low to moderate levels of exudate, you'd be going for your Ergo Clean wafers. Hydrocolloids, we've removed the Tegaderm from the formulary. We were having quite a few problems with skin stripping with that. And then, you know, the little 5x5 hydrocol dressings, we've broadened the sizes available in the formulary, and that's your hydrocolloid now on the formulary, hydrocol bordered. So it's got the little beveled, tapered edges on it, so it's not a thick ridge at the end. And we've only got the regular thickness of hydrocolloid. We found that the thin hydrocolloids limited opportunities for using that appropriately, and that when not used appropriately, they were sort of disintegrating on wounds. So we're just sticking to the hydrocol bordered, which is slightly thicker. And then your retention bandage, so the simple, cheap, easy fix bandage that you had, we've just changed to K-band, just because it's cheaper. These are not bandages that you use on legs. These are bandages for holding things in place. So if you want to hold a dressing in place on an arm, you'd be using a K-band for that. Other changes, so Adaptic Touch, which is your silicone wound contact layer, that used to be in the red zone on the formulary. We've changed that to Active Heal's silicone wound contact layer, more cost effective, good product, and it's gone into the amber zone. So that's patient specific on Halo. So it's a step up product from A-Trauman or NA Ultra. So your antimicrobial dressings, as we said, they're now on the amber section on Halo. We're really hoping that this is going to mean that there's less of a delay for you getting these dressings. You won't have to wait for the GP to prescribe, get the prescription to the pharmacy and the like. So you would go and see a patient, and if you think, oh, I think there's a wound infection here, I'm going to need some antimicrobial dressings, you'd have Inodine in your bag for putting on today. You'd be asking your admin to order that would come in tomorrow, and then you'd be back as soon as you can manage to put the antimicrobial dressing on. So although there is a delay because it's not on your shelves as a stock item, it's far less of a delay than it would be if you're having to wait for a prescription from the GP. So we hope that's going to make a big difference to both yourselves and the time spent arranging these things, but also for the patients getting their wound infections treated more timely manner. So we changed the mechanical debridement pad. So we had Debrisoft, and we've changed it to a new product that's come onto the market called All Prep Pad. This is what you can see in the top right-hand picture here. It's a foam pad, which is essentially there for scrubbing your wound bed, either to get rid of slough to debride, or in the management of biofilm as part of the wound biofilm pathway, which I'll come on to mention in a minute as well. So that's available on the amber section of Halo, NHS number, rationale, how many you need. Algivon and Algivon Plus. So the last formulary had Algivon and Algivon Plus. including the ribbon, but actually Algivon Plus is the company's later model of Algivon, and it was never intended that the regular Algivon would stay as a product that they offered. We find the Algivon Plus easier to cut and handle, so we've got rid of the old Algivon because there's no clinical advantage to having that on. So again, just to make it simpler, so you've got less to choose from, less to confuse you. So there's a change here that may not be popular. So we have removed Actylite from the formulary. I'm sorry about that, because there will be people out there that are firm Actylite fans, and it is a good dressing, and there are times when it is appropriate. Sadly, we find there were far more times when it was used inappropriately, with some harm to patients, and that is when people had a wound bed infection. Actylite was being used, and Actylite is just not appropriate for treating a wound bed infection. If you've got a wound bed infection, you need a far stronger honey than that. We sort of talk about Actylite as being the Inidine of the honey wound, of the honey world. It's for trying to keep microbes down, so that you don't develop an infection, rather than treating an infection. And because we saw so much inappropriate use of it, and the consequences of that are not great for the patient, we felt that that priority outweighed the usefulness that Actylite is in those sort of milder situations where you're just trying to prevent infection from happening. So sorry about that, but not sorry about that. Activon tube, 100% Manuka honey. That is the honey in a tube, as the name suggests. Different to the last formulary, again, going back to 2015, there was a sort of error on that formulary, really. The wound gel, the MediHoney wound gel, is not 100% Manuka honey, whereas this is. And so this honey, you can squirt it into the smallest of holes that go all the way down into the abdomen, if you like, and not worry about not being able to get it out. It's perfectly all right to be left in the body. So if you're needing something, an antimicrobial to go down a sinus, then the 100% Manuka honey is what you need, and that's why we've got Activon tube on there. Cutimed Sorbact, which was the green, dry, meshy antimicrobial dressing, which is our third line antimicrobial dressing. We have changed to Zorflex. So Zorflex is in the bottom right picture here. It's a charcoal dressing. It looks like a bit of black satin cloth. Dry antimicrobials. We changed it because we felt that sort of 50% of the time the Cutimed Sorbact wasn't really doing what we wanted it to do. Yes, of course, there are circumstances when it works well, but on balance we found that we were getting slightly better results with the Zorflex. The Zorflex, again, it has its down points as well. It is prone to sticking onto a wound, but actually if you soak it, then that can alleviate some of the sticking. And sometimes it's more important that you can, I mean, I had one lady, for example, that had really awful microbial issue in her wound, large wound, allergic to silver, allergic to iodines. Honeys were just way too wet for it, and we had real problems finding an antimicrobial she could cope with. So we tried the Zorflex, but it did stick quite badly. But we had nothing else to go with, and the way she's got used to it. The practice nurses have got used to it. They know it sticks a bit, but what they do is they use a mop bucket, which is deep. She puts her leg into it and she soaks it for 5 minutes, submerged underwater, and then it does seem to come off a little bit easier. It still needed to be peeled off, and it's not the same for everybody. Some people don't have any problems at all. But if it does stick, then do think about, right, maybe I need to try and soak this off and actually submerge it in water rather than just splashing water over it. That's worth a try. But we did find on balance, despite the downs of both of them, that there were more pluses with the Zorflex than there was with the Cutimed Sorbact. A word about podiatry there. Podiatry, like Cutimed Sorbact, they have their own formulary. We do communicate and they know about all the formulary changes that we've made. I am encouraging them to really try Zorflex and give it a go, but you may find some of their patients still coming out with Cutimed Sorbact. Then you need to have a conversation with them. You need to say, either we change to Zorflex so that I can order it as well, or you need to provide me or provide the patient with the Cutimed Sorbact so that I can use it when I go there. Yes, hopefully you'll find a mutually happy solution with one of those two strategies there. Another change, Pro Shield, Mediderma Pro Ointment and Cleanser. This is really very similar to the Pro Shield ointment and cleanser. They look the same, they behave the same, they're virtually the same. Mediderma Pro is made by the same company that do Mediderma S, the cream and the film, and it's cheaper than the Pro Shield. So the Pro Shield has not been blacklisted. So if your GP or if you've got a patient who is really fixated on it has to be Pro Shield, the GP can still prescribe it, but otherwise we would just suggest that you either change over when you get a new patient, you start them on this instead. It's just the same, it's cheaper, and if you need some guidance on when it's appropriate to use, the range of different products, you've got one company rep to speak to who will be able to educate you about which of their products is most appropriate. Other new additions, octenolin wound irrigation solution. That's on the amber section in Halo, so NHS number, rationale, and sort of volume. So this is not just to be used on any old wound for irrigation. This is part of the biofilm wound pathway. So you would be using this only as part of that pathway for when you suspect that you've got a biofilm. And that's because it sort of does two things, octenolin, and the main reason why we use it is because it's what's called a surfactant. So when we're trying to debride a wound, to remove slough and to disrupt biofilm, octenolin helps to release that from the wound bed. So surfactants change the surface tension and helps lift things. So if you think about your fairy liquid, if you tried to scrub a dirty pan clean with just water and then you do it with fairy liquid, the fairy liquid helps lift and separate the dirt from the pan. And octenolin does the same thing in wounds with slough and with biofilm. So when you're trying to debride your wound bed with vigorous cleansing with the all prep pad, you'll be using the octenolin with it, and that will help release it out of the wound. It is also an antiseptic, which is a Brucey bonus, really, but we are not using it for just treating a wound infection as such. So you would still be using your antimicrobial dressings, and this would be part of the debridement part of managing the biofilm within that wound infection. So not to be used carte blanche on everybody, only as part of the biofilm. We've put an adhesive remover on there. There wasn't one before. Lifties, evaluated well, to be used for removing painful dressings to prevent skin damage. So that's on the amber section of Halo. The two wrap garments that came onto Formulary last year as part of the chronic edema pathway we put them through on, we've now finally added them into the Formulary documentation. So on the summary document for the Formulary, you will see them listed. The details about these products are in the hosiery Formulary. So the hosiery Formulary used to be just about hosiery, but now we've added in and called it the hosiery and wrap Formulary. And so all of the information about the two wraps and things are there. So we have the Faro Wrap 4000, which is a sock and a wrap for limbs without edema, and then we have the Juzo adjustable compression system, so the Juzo ACS Light, which is for legs with edema, so legs with lymphedema. It says light, but it's not a light product. Both of these wraps are not intended for use with active ulceration, so to try and heal venous ulceration. The evidence isn't there for that yet. So at the moment, they're only on Formulary as maintenance garments for once you've got the skin intact. And then we've got Coban 2 bandaging, which is sort of completely new. And again, that is a lymphedema bandage used via the chronic edema pathway and specifically for very misshapen legs. Or for complex thigh-high hosiery, where you'd need an awful lot of wool and things are sliding down a lot. That's when Coban 2 is appropriate. So what we've also put together or tried to resurrect and renew is a document that compares the Oxford Health Formulary with the OUH Formulary. So when you have somebody discharged from the OUH, you'll see quite a bit of things like flaminol gel coming out with patients. That's one of their antimicrobial options on their formulary. Well, just because they're saying we're dressing it with flaminol gel doesn't mean to say that you have to dress it with flaminol gel. If there's no good rationale why it's flaminol gel and nothing else, then what you would do is you would go, well, we don't have that on formulary. What is our equivalent of that? And this document, the Wound Formulary Comparison Guide, is where you would go to say, right, okay, so they're using Mepilex Border Comfort. What's on our formulary that's the equivalent of that? Oh, Cliniderm silicone border. Fine, I'll use up the supplies provided by hospital, but when we come to need more supplies, I will order the equivalent off our formulary. So please do bear that in mind. We're just putting the final touches on that. The OUH have just changed a couple of things. Then it will be on our website. You will go to where the formulary is. So it'll be on the wounds tab underneath the formulary, and you'll see a link there to the wound formulary comparison guidance. Okay, so where else can you go for other bits of guidance? So this is a picture of our website. If you've not been there, you should have been, and please rectify that as soon as possible. Like I said, you would just Google Oxford Health Tissue Viability and up would come this page. There's 2 rows of tabs, so you can just see the top row there. If you scrolled down, you'd see another row that would have the wounds tab on there where you'd find the formulary. Many other resources on there to support you with this stuff. So we've got a variety of care pathways that help you work out what's the right product to use and when and at what time. So I'm just going to name these here. If you were at the formulary launch, you will have been introduced to these, but you would be coming across some of these on our study days. So we've launched recently a skin tear pathway. I can show you a picture of that in a minute. We've revised all of the leg ulcer pathways. So we used to have a standard venous leg ulcer, complex venous leg ulcer, and a mixed etiology leg ulcer pathway. We've now revised that and incorporated that into one pathway, which is very exciting. There's some radical new stuff on there, and there's some Teams training coming up shortly about it. Again, there should be a video on it on our videos tab that you can see there on our website, and the pathway will be available on the lower limb tab to look at. I mentioned before that the wrap information has been combined with the hosiery formulary, so you can look at that for information, the hosiery and wrap formulary. Compression with heart failure pathway for people with edema in the leg, that's an essential part of your assessment. And we've revised the AMBLE tool, so that is the tool to help you work out if you've got a problem with microbes, bacteria and things in your wound bed. Have you got an overt or a covert infection in your wound? We've revised that and made it simple. It's called the AMBLE 2 tool. And then there's a new biofilm management pathway. We've updated the Exudate management pathway and the skin barrier management pathway. So this is the front of what the skin tear pathway looks like. And this is all about trying to do the right thing first aid wise by a skin tear to try and save that flap, stick it back down and avoid getting a complex wound. And that's where your Cliniderm silicone border is used. There's more to the pathway than that, but that's just what the front of it looks like. This is the compression with heart failure pathway, Anybody that presents with edema as part of your assessment, you want to know if they've got heart failure, because you may need to go carefully with compression. So this teaches you how to look at their records, identify if they've got any heart failure diagnosed already, and if not, is the patient at risk of having undiagnosed heart failure? So what would be the red flags that you would need to think? So if you were looking in their assessment and seeing that they've got a history of AF or hypertension or something, it may be they've got undiagnosed heart failure, and this pathway will tell you what you need to do. If they've got heart failure and it's stable, and again, the pathway tells you how to work that out, it then offers, so how do I commence compression? There's a backside to this, and it gives you a risk managed step-by-step approach as to how to start and build up compression for somebody that's got heart failure. So this has gone through, this is work that's been done in combination with the heart failure team, and has been signed off by the cardiology consultants at the OUH. So if you're following this, you are covered if anything adverse happens to your patient. That pathway you will find on the lower limb tab under the compression toggle. So this is the revised AMBL 2 tool. So have you got an overt infection? So it's obvious. You would have redness, pain, odour, increased exudate. You know, you'd be able to see that you've got an infection. Or have you got a covert infection? We get a lot of referrals for this. So have you got a static wound that's just not reducing? You've got a bit more exudate. Maybe a little bit more of increased pain. It may be that you have got a covert wound infection, and this will help you identify that. And then on the back of this is the management strategies, when you would need oral antibiotics, when you would need a swab, and what dressings you would use and for how long. The purple section on the end is new, and it says basically if you've been through 2 rounds of treatment of a wound bed infection with the AMBL tool, so you've done your assessment, 2 weeks of treatment, you've stopped, it's come back, you've had another go, and it's still a problem, that's when you need to think whether you've got a wound biofilm. And if you're thinking that you might have, you would go on to the biofilm care pathway. So the biofilm wound care pathway looks like this. I know you can't really read what's there, but it starts off at the top in the little pink box, the blush box there, with a checklist of, if you've got 2 or more of these, then you've probably got a biofilm, and you would sort of continue. And then there's a 6-week program. The first 2 weeks, debriding with the all-prep pads and octenolin and using an antimicrobial. Second 2 weeks, so week 3 and 4, still debriding with the all-prep pad and the octenolin, but swapping the antimicrobial to a different one. And then weeks 5 and 6, away with the all prep and octenolin, but you're still going to be vigorously cleaning the wound bed, but with tap water and gauze. And you're going to be using things like Ergo Clean or Aquafiber Extra, depending upon your exudate levels, to try and prevent biofilm from settling in there. So that's your biofilm wound care pathway. That you can find on the wound tab. And then scroll down to the biofilm tab that's there, wound infection and biofilm. You will find the AMBL 2 and the biofilm wound care pathway on there. Wound exudate pathway, I don't know whether you've seen this or not. We've just reviewed this. This has already been in existence, and we've just updated it with the new products that are on formulary. So if you've got a dry wound, what your rehydrating products would be, what's appropriate for low exudate, moderate to high, and very high exudate levels. And then your skin barrier management pathway. I'd hope the majority of you would have seen this. This is a good one for sticking up on your wall. When do you use Mediderma cream? When do you use the film? When do you use the spray? When do you use the foam buds? When's it okay to step up to the more advanced products, Mediderma Pro, etc. And then also, when do you sort of step back down again? I've always got really quite confused with that, particularly when to use the cream or the film. And you might find that printing some of these off and sticking them on a notice board is a good thing. If you're IT savvy, you can download them and save them on your phone so that you can refer to them whenever you want to. And then I just mentioned that this is a copy of the compression hosiery and wrap formulary. You'll find that on the lower limb tab under compression, and it's got the wrap information in there. Okay, so that is the end of my presentation. I just encourage you to have a little look at the formulary on the website. As I said, we did issue on the day a paper copy to everybody, a printed copy, and we will be sending round more. If you have a lack and you feel you need one, you've got two options. You can always try emailing us, and if we've got spare copies, we could send one. Or you can go onto the website and you can download a copy and you can print that off for your team. The more important thing in my mind, yes, the rainforests are important, but your patients are important too, and you using the right products for the right indications of the wounds is important. And if having a couple of paper copies printed out in the office is going to help you do that, then I would say that that's okay. But you know, don't be crazy. Don't print one off each, so you've all got one in your car, because that's not great use of paper or colour printing. Okay, many thanks.